Good evening. Thank you, Lori. Thank you, Virginia Heritage, for inviting us. My name is Prasad. I'm one of the interventional cardiologists in the community. Dr. Ian Turner is one of my partners at Oracle Heart Vascular, and both of us do vascular disease as well as coronary disease at Mary Washington, Stafford, and our private practice offices. So today, you have invited me to speak about peripheral artery disease, which is kind of doesn't get much reviews in the press. I mean, everyone knows about heart attacks, everyone knows about strokes, everyone knows about atrial fibrillation, but peripheral artery disease needed a month to commemorate it in order for some people to start thinking about it. So let's get right to it. Peripheral artery disease, born to walk, born to run. All right, some honorable mentions on how we got here. PAD, the last major pandemic of cardiovascular disease. This was Dr. Alan Hirsch. He was a vascular surgeon. He was a pioneer in the forefront of vascular disease, not only vascular disease research, but also intervention and therapy. But most importantly, in his partner's trial, really raised the awareness of the prevalence of peripheral artery disease in the community and its impact on long-term cardiovascular mortality. This is Ariana, no relation to Dr. Hirsch. She is 8 years old, she's precocious, and although she wants to be a physician one day, like her dad, I tell her she's too argumentative and should just turn to law. We were at dinner a couple of weeks ago, and I was reading Dr. Hirsch's statement about the major pandemic and how he described cardiovascular disease and PAD in specific as a pandemic. So, like some fathers do at the dinner table, in order to sound important, you ask a question that you yourself already know the answer to. So my children are there, my two sons and my two daughters, and then I said, what do you think is the world's worst pandemic? Daniel, my second son, immediately raised a hand and he says, COVID. To Daniel, everything's COVID, even though it's been years after. My older son, Gabriel, looked thoughtfully and he looked at me and he said, the bubonic plague. And I said, not a bad answer. Ariana was sitting at the table, eyes fixed on the TV in the living room, and I was waiting for her answer. And I said, Ariana, what do you think is the worst pandemic? No answer, just looking at Bluey or whatever she was watching on TV. I said, Ariana, you have an answer? Don't you have anything to say? Nothing. Continues to ignore me. I finally raised my voice a little bit. I said, Ariana, what do you think is the world's worst pandemic? She looks at me. Ignorance. Turns around and continues to watch TV. And I was dumbfounded. I didn't know, I was half impressed by her deep and philosophical answer, and then also confused if she had thrown the slightest offense towards her dad. But in any case, here we are, preaching the gospel of cardiovascular disease to eliminate pandemics, and hopefully by the end of this, you guys all leave the room with a little less ignorance. All right, so let's start with some definitions. So with this talk, I'm going to try to keep it to a point where we just build up slow arguments and concepts, and then at the end of it, you can put it all together and have a fairly good understanding, at least from a clinical standpoint and from a patient standpoint, what are the things and what are the mechanisms and the symptoms you have to be aware of for peripheral artery disease. So forgive me if at the beginning it's a little bit basic, but just follow with me and we'll get to where we need to be. What is atherosclerosis? Now, atherosclerosis is what our great-great-grandparents used to call hardening of the arteries, okay? It was something that when I remember in medical school, when we did autopsies on patients who died of heart attacks, and we looked at their hearts, and we saw the coronary arteries that sat on top of the heart, they were hardened. They were like casts, all right? And this is how arteriosclerosis, which is hardening of the arteries, was initially understood. And it was kind of taught in medical schools as clogged pipes. As our techniques and our research and our understanding of biology evolved, we understood that it wasn't arteriosclerosis, it was atherosclerosis, which is basically a condition in which plaque builds up in our arteries, okay? We are the only species on the planet that builds up plaque in our arteries. Now, we're not born with plaque. Our arteries serve as conduits to serve and nourish all the organs. So from the heart at its epicenter, it reaches out to all parts of the body to nourish, bring oxygen, and then also remove waste. Atherosclerosis is the process by which those conduits start to develop plaque, and mostly through factors that contribute to chronic inflammation. Okay, so atherosclerosis is the buildup of plaque in arteries that eventually can, in certain circumstances, lead to the obstruction of those arteries. And when you obstruct the arteries, what happens to the organs that they serve? The organs suffer. Okay, so that's atherosclerosis. So from that, atherosclerotic cardiovascular disease, ACV, is any mechanism or any manifestation of disease where you have plaque building up in different arteries. Okay, so with a buildup of cholesterol plaques in arteries, anywhere it goes, so if it's in the head, if it's in the heart, if it's in the kidneys, these are all under the umbrella term of atherosclerotic cardiovascular disease. So this includes everything. So now if we proceed and if we extrapolate from that, one part of atherosclerotic cardiovascular disease, peripheral artery disease, is a subset. And peripheral artery disease relates to atherosclerosis, the buildup of plaque and subsequent obstruction, involving the aorta, which is the mother artery, and its peripheral branches, the iliacs and the lower extremity arteries. It also includes the upper extremities as well. Now, you could understand, if we look at the whole circulatory system here, the heart at the center, you have the aorta down the middle, and it supplies everywhere, all the different corners and nooks and niches of the body is reached by some sort of artery or arteries, capillaries. Now, when any of those arteries build up with plaque, you develop damage to the organs, or the organs that it supplies are threatened. So when it happens to the kidneys, what are you in danger of? Strokes, okay? When it happens to the heart, you're in danger of coronary artery disease, okay, or what ultimately causes heart attacks. When it happens to the aorta itself, the aorta doesn't obstruct because it's a pretty big vessel. It starts to dilate, and you get aneurysms, and ultimately things like dissections and ruptures. And when it happens to the arteries of the extremities, you get peripheral artery disease. Okay, so does everyone understand that? So peripheral artery disease is just another manifestation of atherosclerotic vascular disease. And if you understand that one concept, then you'll understand the most important part and idea and principle of this. That if this, number one, that this is not a local problem. Remember, initially they used to think that it was clogged pipes. People thought that it was a blockage in the heart and it was isolated in the heart. However, we now understand what? That this is not an isolated local issue. This is a global or systemic issue. So if it's a systemic issue, then you have to think of all the implications that follow. Number one, if you have heart disease, you are more likely to have cerebral disease. So a person who has a heart attack is at higher risk to have a stroke. A person who has an aneurysm is at higher risk to have a heart attack. So you create this continuum of vascular disease that basically affects the entire body. So the first thing you understand is that this is not something local. This is not an issue of clogged pipes. Okay, the second thing you understand is if this is systemic, then certain principles that we can apply to one apply to the other, meaning risk factors for inflammation and plaque buildup in the heart is similar to risk factors that leads to inflammation and plaque buildup in the head. Okay? Furthermore, in addition to just risk factors, the way we treat these things, the way we treat vascular disease has certain general principles. For example, all vascular disease requires lifestyle changes, period, full stop. Okay? And these lifestyle changes in some way reduces systemic inflammation. All vascular disease require pharmacotherapy. There are certain medications which have been proven beyond any doubt that reduces the impact of death, the impact and the likelihood of death from from MIs or strokes. And then finally, all vascular disease has certain interventional indications where you need to go and actually open up a clogged pipe. Okay, but the primary problem isn't the clogged pipe, it's the body and the vasculature itself. And really as physicians and operators, our biggest challenge and really the sign of our maturity as proceduralists is understanding when to intervene and when we should focus on lifestyle and medications, okay? So this phenomenon of polyvascular disease is something that's very important to understand, because remember, there's no such thing as a person who just has a heart attack. They have vascular disease in the head, they have vascular disease in the legs, they have vascular disease in the aorta. So you need to treat them as a person, and not just the organ that is compromised at the moment. Now, this is something that when we bring it back to peripheral artery disease, this is a graph looking at different patients with different vascular phenomena. So at the top, you see a patient, these are all PAD patients, so they have peripheral vascular disease. The top bar are PAD patients who've had a stroke or an MI, okay? And then the axis here shows your risk of additional or recurrent stroke or MI. So you can see patients who have peripheral vascular disease, who've had an MI or a stroke, are what? They're 14.9% higher risk of having another one. And that kind of makes sense, right? You've already had a phenomenon and you're gonna have it again. All right. What's most interesting is in patients who have PAD, but never had a history of stroke or heart attack. And you can see, compared to those without PAD, that even their mortality is 10.3%. So their incidence of major adverse cardiovascular events, which is cardiovascular death or MI, is 10.3%. So it becomes very important to understand that. So even if you've never had a heart attack, you've never had a stroke, but if you're diagnosed with PAD by itself, meaning you've demonstrated that there's atherosclerotic plaque in your extremities, your risk of death from a vascular event is 10.3%. Now think about that. Now compared to finally patients who've had no MI, no stroke or PAD, they're the lowest, 7.6%. Okay, so it comes down to the fact that PAD should be sought, because as soon as you find it, now you're also going to be able to define their risk of stroke and heart attack. Okay, and this will also start building up the argument why we screen for PAD rather than just trying to diagnose it when people complain about problems. Okay, PAD is an independent risk factor of cardiovascular mortality. All right, let's go through the numbers. So both globally and nationally, the numbers for PAD are increasing, okay? So the global prevalence of PAD was 5.6%, which translates into 236 million adults. We notice that prevalence is higher in higher income countries than low and middle income countries. But when you look at population size, meaning if you just look at the populations, you have larger populations in low and middle income countries. The total individuals with PAD are in low and middle income countries, okay? And when you look at even high income countries like our own, when you look at the prevalence of PAD, it's actually in the lower to mid socioeconomic status. So there's a huge socioeconomic disparity and cultural and ethnic disparity, which we're recently starting to understand and study and treat within the population itself. And the prevalence of PAD has increased from 2000 to 2015 by 45%. Okay, so the bottom line is PAD is increasing worldwide, most obvious in lower middle income countries. And this is the projection, and it continues to rise. In the US itself, it has increased from 11.3 million in 1995 to 21 million. And there are also, like, as I mentioned again, there are serious gender and racial ethnic disparities. So PAD is increasing in the US. Now, this is what's really telling. So if you look at 10 million patients with PVD in the US, 2.5 million are diagnosed. So actually, this is undiagnosed patients. And only 400,000 are treated. So we're not even catching the total number of patients. So out of the 10 million patients who have PAD, only 2.5 are being diagnosed. So, and out of the 2.5 that are being diagnosed, only 400,000 are being treated. So it's not only being underdiagnosed, it's being undertreated. And then you will see when you follow that line out, as far as outcome, it increases their risk for mortality and things like that. So why do we do this? There's underutilization of testing. People, I think, just by their perception of it, they don't think of it. I mean, everyone thinks of a heart attack as something serious. Everyone thinks of a stroke as something serious, but no, it's not really on anyone's radar that peripheral vascular atherosclerosis can be as serious and also prognostic of both of them. And then the last thing is their symptoms isn't as clear cut as like a stroke or a heart attack, because the truth is most patients with PAD are asymptomatic or have very atypical symptoms. So imagine that there's people walking around with vascular disease and most of them have no symptoms. Whereas in coronary disease and cerebral vascular disease, we are more tuned to see symptoms and look for symptoms, whether it's angina, whether it's exertional shortness of breath, and things like that. But with PAD, they can have, half of them have no symptoms. And that also makes diagnosis challenging. So now moving on to risk factors. Now remember, I said with vascular disease, because this is a systemic effect, they share certain risk factors. All right, and I usually divide it into those things we can change and those things we can't change. Okay, so at least with non-modifiable, age is definitely something that correlates clearly with vascular disease in general. Above 65, 70, the incidence of vascular disease, whether it's PAD or other, increases. Sex, in general, atherosclerotic disease is a little bit more weighted with men over women, in general, for example, coronary disease and strokes. However, in PAD after 70, they're actually around the same. They're equivalent. When we look at modifiable risk factors, the two, possibly three, that have the highest weight in contributing to the development of lower extremity atherosclerosis is diabetes and tobacco use. So if I have a patient who is a smoker and a diabetic, we know that they have vascular disease. It's just a matter of catching where. Because the two phenomenon are synergistic. They're both inflammatory, and they increase the effect of inflammation of one another significantly. So patients who are longtime smokers, and especially uncontrolled diabetics, they're vasculopaths, period. And so it also now builds up the argument that we need to look for these diseases. And when we try to weight them on which contributes more to PAD, smoking contributes more to PAD than CAD and stroke, diabetes, triglycerides, and microvascular disease, meaning if you're diabetic and you already have retinopathy, meaning the small vessels of your eyes are involved, or if you're diabetic and you have kidney disease, nephropathy, these are more likely to have more predictive and associated with having peripheral vascular disease. Okay, so those are the risk factors. And it's important to know the risk factors only because, remember I said when we get to the part about treatment's always three things: lifestyle, medications, interventions, okay? Lifestyle is something that you don't need a prescription for. So if you understand the risk factors, and if you identify that you yourself have those risk factors, then it only follows that part and parcel of your treatment is to address it and appropriately make the changes for those risk factors. This is a graph looking at the effects of smoking. So the upper chart is looking at Parke smokers. So here, these are they're each on CAD, stroke, and PAD risks. Okay, so the first three here are never smokers. So you can see that their hazard ratio is 1. There's no additional risk. When you start adding the years, so this is 10 years, this is 10 to 25, this is 25 to 40, this is 40 Parke years. Now, the third line in each of these triplets is the PAD risk. So you can see here, there's nothing that's coming off of the 1. Once you get to 10 to 25 years, PAD jumps off the line. So once it comes off the line, the risk starts to increase. You can see here, by 25 to 40 pack years, you're already at 4 times the risk of having PAD. 4 times the risk, and still look, CAD and stroke is still between 1 and 2 times the risk. So you can see the effect of tobacco use, how it significantly increases your risk for developing PVD. If you're more than 40 pack years, you're already up here. Now, this is the inverse of that. Let's say you quit smoking. Now, when you quit smoking, the reduction of risk for heart attacks and strokes occur earlier. So here, these were never smokers. These are people who've quit after, these are current smokers. These are people who've quit the earliest, more than 30 years they've quit, and you can see that they've already, the CAD and the stroke has already returned. Actually, all 3 of them have returned back to normal. However, you can see when you look at CAD and stroke risk returning, it returns here. This is less and less. This is less further from the time that they quit smoking. So here, PAD, even at 20 to 30 years, your PAD risk is still 2 to 4 times. It doesn't return back to the normal line. Whereas right here, which was less than 5 years, so if you quit smoking in less than 5 years, number one, your stroke risk already normalizes, and your CAD risk is coming down, but you can still see the PAD risk is still up there. So the bottom line is, if you smoke, it significantly increases your risk for stroke, heart attack, and PAD. If you stop smoking, the longer it's going to take for that risk for PVD to come down before, after CAD and stroke. So there's the importance of smoking cessation. Diabetes. With tobacco use, diabetes is one of the strongest risk factors for PAD. And specifically, patients with diabetes have the severest form of PVD, which is basically organ damage, which is you start losing limbs, right? You have gangrene and things like that, and we'll talk about that. But diabetes accounts for 70% of cases that undergo amputation. So diabetes control is extremely important. So now we're going to talk about symptoms, and I wanted to kind of walk you through the mechanism of why we develop symptoms. So remember, the basic mechanism is what? What's happening at the vessels? You're getting plaque. Now initially, that plaque, which is made up of cholesterol and inflammatory cells and platelets and things like that, the vessel, which is a tube, actually absorbs the plaque into the wall, okay? So it starts, so we call it remodeling. So it wants to preserve that space, that lumen, to allow the blood to flow through. So what does it do? It starts to adapt, and it starts to go into the wall. Now there's a threshold after which it starts to now grow into the lumen, and it starts to slowly close that vessel down. Now, the body, still in its miraculous capacity, adapts. So as that artery is starting to close down, what it does is it will start creating collateral. So you can see this is a clean artery. You have the plaque that it's building, but now it's gotten to the point now the plaque is now encroaching into the lumen, pushing into the space where the blood is flowing. And when this happens, new arteries start to form around it. We call them collaterals. They're small little finger-like arteries that come parallel to the parent artery. So what is it doing? It's saying like, listen, I can't afford to lose my foot. So it starts growing new arteries. Now those new arteries are very good at keeping the foot attached and keeping it perfused and keeping it from coming off or start getting damaged. However, there's going to be a threshold at which those arteries aren't enough. And that's when they start developing symptoms. So again, so you got the blockage, you start developing collaterals, and then those collaterals are good when you're just standing there, but then what happens when you need more blood? When do your feet need more blood? When you're walking. So when you're walking, the muscles in the legs are saying, listen, I need more nourishment, I need more oxygen, and it's asking and drawing more blood, but the blood is now stunted. Now the blood and the collaterals are inadequate at that threshold now to do it. It's good when you're just standing there, but when you start walking after 10, 15 minutes, the muscles are being starved, and what does the muscles do? They ache. Similar to what happens in the heart. When your heart's arteries are occluded, what do patients with heart disease? They have angina, which is classically chest pain or pressure. So once the artery closes, now you end up having the end organ issues with peripheral disease, which is gangrene and limb ischemia. And that's when you become in danger of losing your legs. So understanding the mechanism, now you can understand how patients are going to present. Remember, we said that the most challenging thing is most patients are asymptomatic. There's no symptoms, or they're atypical. Now, this is the patient that either, I've had some patients that are just very stoic, don't complain about anything. But if you dig a little bit deeper, Mr. Smith, how are you walking? Oh, I'm doing okay. He's able to get around the house and stuff. But then he says something like this. I'm like, Mr. Smith, how are you able to get to the mailbox? And unlike New York, mailboxes in Virginia are a little bit further out than what I was used to. And usually people get a good walk to their mailbox and back. And Mr. Smith would say something like, well, I just pick up the mail when I pull the car out. So patients will start inadvertently changing their own behavior to mitigate those symptoms which are developing. Their legs start feeling tired, so they don't want to walk to the mailbox. So what they do when they're going out for groceries, they'll stop with the car and then do it. So you can understand they're not really asymptomatic, and sometimes in these patients, if we're suspicious, we actually ask them to walk on our treadmill and see how they do. But most of the patients are asymptomatic. They have functional impairments compared to claudication. So patients who are actually asymptomatic, they're still as active as the patients who are developing pain because they've changed their behavior unconsciously. And what's even more astounding is that even the asymptomatic patients, their risk for death and cardiovascular morbidity, mortality is as equal as the ones who are having symptoms. So you can imagine, go ahead.
What is claudication?
We're going to get to that. And then this also underscores the importance of screening, because the only way to screen for patients without symptoms is, the only way to find disease in patients without symptoms is screening. Now, symptomatic patient, and this is intermittent claudication. So these are the patients you wish you want them to walk into our office. These are patients who've developed that plaque over a long time. They've developed their collaterals, but now those collaterals are insufficient. So what do? They say, hey, I usually go for a walk with my wife, or I walk the dog every morning, but you know what? After 15 minutes, and it's always a very precise distance or time, they say, I stop, okay? Intermittent claudication, it's intermittent, means you have exertional leg pain or symptoms. Those symptoms can be burning, tingling, aching, cramping, whatever it is, but it is related to their walking. And when they stop, within 10 to 15 minutes, the pain resolves. That's classic intermittent claudication. Okay, it's the legs version of angina, right? Angina is chest pain from the heart. So same thing, intermittent claudication, and remember, this is a minority of patients, and the symptoms can be anything. So if I just hear symptoms being brought on by walking and then resolves after 10, 15 minutes of rest, that's claudication. I don't need to hear what type of pain it is. It's claudication until proven otherwise. So we have symptomatic patients. Now, if you take symptomatic patients and take them to the extreme, where now you're not only having temporary ischemia in your muscles and your tissues, now you have permanent damage, meaning the tissue is starting to die. Now, you can divide that into chronic limb-threatening ischemia, which is if these symptoms are happening for more than 2 weeks, and then you have acute ischemia or acute limb ischemia, which is when it happens very quickly. But basically what happens is, number one, these are the severest forms of PAD. These are also related usually to amputation if they're not caught and treated appropriately. The only difference is the time period. Chronic limb threatening ischemia is more than 2 weeks of ischemic pain, and now you have evidence of tissue damage, whether it's non-healing wounds, ulcers, or gangrene. And these are usually associated with the most major and minor amputations, okay? In patients who've had an amputation, and this is another thing I want you to understand, 1 year mortality after you get your leg, whether it's above the knee, below the knee, or your foot, is 25 to 35%. So this is independent. So if a patient loses their leg or foot, now this is from vascular disease. I'm not talking about trauma and other unrelated things. From vascular disease, their risk of cardiovascular death in the next year is a quarter. Okay? God didn't make us to have no legs. So the prospect of losing or taking someone's legs should be the last option to a surgeon or any physician or anyone. Okay? 1 year rate of amputation in patients with CLTI is 30%. So if you're presenting with it, there's a 1/3 chance that you might lose that leg. And if you do lose that leg, there's a 25 to 35% chance that you're going to die in the year following. Okay? Losing legs is not something that should be taken lightly. And in the world, we have the highest amputation rates than anyone. And that's changing, but it's changing as our understanding of vascular disease, and now that we are developing better methods of revascularizing. Medical therapy has improved, lifestyle education and things have improved, but still amputations do portend a poor prognosis in the long term, and the prospect of removing legs or extremities is a last option. Then acute limb ischemia is if the same thing happens, but it happens suddenly. And usually this is from something clotting the vessel very abruptly. Okay, and this is usually, it can be thrombus, it can be embolism, it can be injury. Sometimes it can be from the procedures we ourselves do. It activates certain clotting factors. But in those cases, the entire leg becomes immediately ischemic, and they develop symptoms as pain, pallor, pulselessness, paresthesia, and paralysis. And the risk of amputation becomes very, very high unless you restore vascularization ASAP. Okay, so those are the basic clinical presentations of symptoms. So you don't want to get to, at least me and Dr. Interno don't want to get to the point where we see chronic limb-threatening ischemia or acute limb ischemia. We try to catch the patients when they're in the asymptomatic or in the symptomatic phases. Now, how do we catch the disease? Does anyone know what's the difference between diagnosis and screening? So you have a test that you're going to use to diagnose something, and you have a test that you're going to use to screen something. So who's had colonoscopies? Okay. So colonoscopies at 45 is a screening study, right? Is a screening recommendation. It's because colon cancer is high prevalence in our country. They're saying, listen, we're not going to wait for you to develop colon cancer. We're going to screen the population at risk for colon cancer. So everyone, it used to be 50, now it's 45. It's earlier if you have a certain familial risk. But basically screening, you don't need to have any symptoms. You're not trying to, you're just saying, hey, this is a population at risk for whatever reasons. And we're going to just apply this test across and catch early signs of the disease. Okay, so someone who's undergoing a colonoscopy for screening purposes, they're looking for polyps because polyps are the precursors to colon cancer, right? Versus someone who's coming into the hospital with a bleed, right, who's got blood per rectum. In that case, the same test, the colonoscopy, becomes a diagnostic test because we have a clinical finding that's not normal, and we're using the same test to say, hey, we need to go and find where this source is. So the same thing with mammograms, same thing with prostate exams. So there's certain disease phenomenons in our population that related to either certain lifestyles or certain age or other kind of risk factors. We say this is a big enough problem as a society that we need to go look for it, okay? So with PAD, remember, most patients with PAD are what? They're asymptomatic. And and we know from the global and the national numbers that the prevalence is very high. So what do? We're going to go out and screen for them. Same test, but the purpose is different. I'm not going to wait for the person. I mean, it's a slam dunk when someone walks in and tells me I'm having leg pain. Then it's easy. It's a diagnostic test. But in this setting, we identify patients who are at risk, and then we screen them. And at our practice, every new patient who walks in through the door, RMAs, go through this algorithm, and if they qualify, we're going to screen them. We're going to screen them if you have certain cardiovascular risk factors and a certain profile, because we know that we're not going to wait for you to be to the point where your limbs are being threatened or you're developing symptoms. And we know that because the prevalence is high, and also we know that most people are asymptomatic, we're going to go look for it. So these are the patients that we look at that are at risk. Anyone older than 65, because remember, one of the biggest risk factors was age. Anyone who's between 50 and 64 who has risk factors for atherosclerosis, so diabetes, smoking, or family history. So if you're 65 or over, you walk into our office, you're going to get screened for PAD. If you're between 50 and 65, if you have risk factors, especially diabetes and smoking, we're going to screen you for PAD. This is based on the guidelines from our American College of Cardiology and American Heart Association. If you are less than 50 with diabetes and an additional risk factor, then diabetes itself increases your risk significantly, that those patients should be screened. And then most importantly, if you have patients who have established vascular disease in an other territory, so if a patient's had a heart attack or had a stroke or had an aneurysm, our threshold to screen for those patients are low, because we know that if they have it in their head, they're going to have it in their legs. So we actively screen for these diseases according to our guidelines. And the technique that we use and the test that we use is an ankle brachial index. And basically what we do is we check your blood pressure in your arms, your brachial, and then we compare it to your ankle pressure. The basic concept is if circulation is intact, the blood pressure that we can measure in your arms and the blood pressure that we can measure in your legs should be close, right? There shouldn't, when you put the ratio, it shouldn't be a big difference. When we start noticing a disparity in the ratio and the ratio starts to decrease, that is a good and very predictive indicator of PAD. And that's usually the gatekeeper for us. It's a very simple test, it's non-invasive, and basically requires a cuff and a small Doppler. Okay? And any patient, so normal should be 0.9 or above. Anything below that is positive. And then depending on how low you go, then we look at how severe it is. But this doesn't tell us where the disease is, it just tells us you have disease somewhere between the arms and the legs. Okay, so that's what we use. So this is our version of the colonoscopy, you can say. Okay? Now, there are some arteries that are non-compressible. You can't get a blood pressure, especially in patients on dialysis and kidney disease. So then we transition to what we call the toe brachial index. We use their pressures from the toe. Now, the other benefit of this test is it can predict your risk of mortality. Okay, so normal is what? It's 1, right? So we said anything less than 1 or 0.9 is abnormal, right? So as we go to the left, this is getting more and more abnormal. This is your hazard ratio for death. And you can see that around 1.9, everyone, there is no additional risk. Once you start going lower, your risk for mortality increases. And then we also saw that at the very other extreme, 1.4, and these are patients who are non-compressible, they have similar mortality. So the ABI not only is a useful tool in just kind of screening the population and looking for vascular disease in their extremities, it also is actually very predictive on their likelihood of some sort of cardiovascular event afterwards. So the lower your ABI is linked very closely and directly to your overall risk of mortality. And then after the ABI, if the ABI is abnormal, then what we'll do is we'll do more sensitive testing and imaging testing to now find out where between the arms and the legs your blockage is. And we'll do, usually at our practice, we'll use an arterial Doppler. Sometimes we'll do a CTA. Sometimes they use pressure volume recordings. But ultimately, we try to first identify and localize where the severe occlusions are. And then once we have an idea if it's a right leg, if it's in which artery, then the last phase is actually imaging. And that imaging can be done with a CAT scan or an MRI, or it can be done invasively with an angiogram. This, you don't have to worry about this. The only reason I put it was this last thing. Do not perform invasive or non-invasive anatomic assessments for asymptomatic patients if they have nothing. These are patients without the risk factors and not. So if they have no risk factors and they don't fall into one of those criteria we mentioned before, so every patient doesn't get a screening, but they have to fit those criteria or have symptoms. Management and treatment. Remember, I said with the management and treatment of all vascular diseases, there's three parts. Lifestyle, because you have to modify those risk factors we talked about, because those risk factors are the same across the board. Number two, pharmacotherapy. There are certain medications that are vascularly active and help reduce events. And then third is, when do we proceed with doing something invasive, meaning surgery or intervention. And I think for most of us, what's important is lifestyle and guideline-directed medical therapy. Smoking, the minimum that a patient with PVD should do is, if they're a smoker, they have to stop. Number two, if they have other risk factors like hypertension, if they have diabetes, we are very aggressive in finding the means to control those risk factors. And the last thing is exercise. And I'll talk to you a little bit about exercise, but nothing impacts the reduction of the severity of PVD and also long-term outcomes, as well as tolerating and also keeping arteries open once we intervene, as walking. Okay? Medications is probably beyond the scope of this talk, but antiplatelets like aspirin, statins, ACE inhibitors, and anticoagulants. And then invasive strategies we'll talk about very briefly. But those are basically the three kind of general categories. And that's the same thing for strokes, same thing for heart attacks, aneurysms, always lifestyle, pharmacotherapy, and when do we need someone to go inside and check. Okay? Now, when we look at treatment, there's two strategies. You want to reduce your risk of death, which is cardiovascular death, MI, or stroke, and you want to feel better. So one of my mentors in New York, he said there's only two things that a doctor can do. Doesn't matter how good they are. They can either make you live longer, which is not as much as they think, and number two is make you feel better. And both are equally important. So strategies for vascular disease is the same thing. You decrease the risk of future cardiovascular death, and you improve the quality of life. Now, some of these things overlap. Discontinued tobacco use helps you feel better and helps you live longer, okay? Walking helps you live longer, helps you feel better. So those are the two things that we know will impact both. Medications, some will make you live longer, but they don't necessarily make you feel better. And you can see that the things that actually do both, that make you live longer and feel better, have nothing to do with pharmacotherapy. It's just something that you just have to change in your life. Finally, exercise. So we always prescribe supervised exercise program. Now it's a hard thing to logistically do. It basically means you need to have a structured program. Usually it's associated with a hospital or a rehab center. And you basically have to enroll the patient, and they have to walk on a treadmill for 30 to 45 minutes. They have to walk until they get their symptoms, which is claudication, and then we try to incrementally make them walk longer while they're obviously being observed, okay? And we've shown that as far as delaying the onset of claudication and the maximum pain that patients feel with claudication, just by walking more, they can push that out. So if a patient if a claudicant gets symptoms at 100 feet, if you send them to a structured supervised exercise program and they're making him walk 110 feet, 150, he will be able to increase that distance before the onset of symptoms. And additionally, the severity of those symptoms will be decreased. Why? Because it does a lot of modifying factors and stimulates a lot of modifying factors, one of which is actually the creation and the growth of those new vessels, those collaterals we talked about. Okay, so it's the mainstay. So for any patient who has PAD, although I get paid to blow up balloons in arteries and stuff, the actual mainstay of treatment for these patients is number one is exercise, is supervised exercise if possible. And we try to refer everyone who are in our PAD program to the program at the hospital, but we need them. And more importantly, it's just as important after we open up the arteries. Dr. Interno and I, we've opened up so many patients who we've struggled for hours to open it up. We've restored flow. The patients feel better. They are walking. They continue to smoke, and within 3 to 6 months, they're back because they didn't walk. And I always tell my patients, like, listen, your artery in the leg is open, but you need to use those arteries. And when you walk, those muscles are drawing that blood through. And if you're just sitting there and you're not increasing the demand, you're not going to keep your arteries open. So we really encourage that, especially the ones that we intervene upon, that walking is extremely important. Okay. And these are just the medications, which basically is aspirin, statins, and blood pressure medicines. Okay. Finally, when does it get to us? All right. The last principle, the last strategy for therapy is when do we have to go in? And there's always two methods. There's surgery, where they provide bypass, so you have a blockage here, and you create another conduit across the blockage, and then sew it onto the artery. Or what Dr. Interno, what I do is we go in with balloons and stents and try to open up those blocks. We try to push the plaque across. Now, unlike the coronary arteries, the heart's arteries, where we stent relatively liberally because it keeps those arteries open better, we're not as aggressive with stenting legs. Just because, number one, they don't stay open as well as they do in the coronaries, but also you have a lot of flexion, and especially across joint spaces, we don't like to stent. So stenting is not something we frequently do. We do it in certain situations, but it is an option, and as stent technology improves, that may change in the future. And the only indications for invasive strategies is if you have symptoms that are refractory, that continue to persist despite making lifestyle changes, including an exercise or walking program, despite optimal medical therapy. And then that's one indication. And then the second indication is when you're in those latter two severe extreme indications, when you have chronic limb ischemia where the leg is gangrene, or you have acute leg ischemia where the leg is also being threatened. Those are the two indications at least a vascular surgeon or a peripheral endovascular specialist should come in and evaluate the patient to possibly intervene. Just a few words about our practice in Fredericksburg. Dr. Interno, who's with me today, inaugurated and started our vascular program when she joined the practice about 5-6 years ago. She was trained from NIH to Hopkins to Hospital Center, and we were fortunate to have her come and start our vascular service line. And since then, it has significantly grown. Our patient base has grown in that service, and to kind of complete it, I mean, in addition to the pharmacotherapies and the general consultations we provide, last February we did open up a procedural suite. And this is a suite with a C-arm where we bring patients, and both me and Dr. Interno, we screen these patients carefully. So there are still patients that we'll take to the hospital. But for most things, especially below the groin, if it's below the inguinal ligament, we will attempt to open these arteries up in our lab. And it's been a great success. We put a lot of time upstream identifying the patients, talking to the patients, and then we actually sit down and we formulate a plan. And usually these procedures, unlike in the hospital, you'll find both of us in there. So we have 2 physicians in there, and we've done about 200 patients total? Not since February, but in the last 2.5 years. But I think at least since February, we've done about 60 to 65 patients. And this is our team. This is Dr. Abdullah. He does vein work. And this is Emily Barnes, our vascular NP. All right, let's get to the end. Conclusions. All right. Peripheral artery disease represents a spectrum of atherosclerotic vascular diseases. Remember, that includes from head to toe: cerebrovascular disease, coronary disease, aortic disease, peripheral disease. And it ranges from simple symptoms as claudications to acute limb ischemia. PAD represents an independent predictor of cardiovascular mortality. Remember that one of the few graphs I showed you, that even if you never had a stroke or a heart attack, but we find that you have blockages in your legs, your risk for mortality is much, much more higher than someone without. So it becomes very important to screen these patients. The absence of typical symptoms and the significant prognostic implications of PAD diagnosis requires screening. So most of the time we find these patients isn't through the ones coming through with leg pain. We identify their risk factors, and if they meet the criteria dictated by the guidelines, we say, okay, we should screen them. And then we do the ankle brachial index. ABI remains the gold standard to screen and diagnose PAD. And also, after we open up the artery, it also becomes a way we monitor your therapy. So every 3 to 6 months, you get a repeat ABI. As long as it's staying close to 1, we don't have to go back in. The cornerstone of therapy is medical therapy and lifestyle modification. Not adherence to medical therapy worsens long-term outcomes. Invasive strategies, which is either surgery or endovascular, is reserved for refractory symptoms, meaning patients who have already tried exercise and still having symptoms, and to save their limb. Amputations are associated with decreased survivability. All right, most important, run if you can, otherwise walk, but no matter what, you keep moving. And I always tell my PAD patients to remember Newton's first law of motion. A body in motion stays in motion. You might, that's Dr. Interno. She's also does Ironman. So and if anyone knows it, she never stops moving. And a body at rest stays at rest, in peace. Thank you for your attention. Have a good evening.